My name is Commissioner Frank Avila, and I'm a commissioner at the Metropolitan Water Reclamation District of Greater Chicago. And the topic of our show today is congenital heart defect. And I have three experts in their field to talk about our topic, congenital heart defect. I have with me Dr. Bassem Mora. He's the director of the pediatric cardiac surgery at the Coomer Children's Hospital, the University of Chicago. And I have with me Paul R. Millman, Vice President of Leadership Guild, American Heart Association Midwest Affiliate. And I have with me an expert in Mended Little Hearts, Joe Kolwitz. He's the Midwest Area Regional Director of Mended Little Hearts. Thanks for being on the show.
Thank you.
Thank you.
And on this question, Doctor, when you think of heart disease, you tend to think of older people like myself or like Joe, and but not babies. And how prevalent is congenital heart disease in newborn?
Yeah, I mean, congenital heart disease or congenital heart defects are the most common congenital anomaly of babies that are born. So of all the congenital anomalies, of anything that can happen at birth, the problems with the heart, with the baby's heart, is the most common problem that happens. It represents about 1 in 120 live births have a problem with those hearts. And overall, if you look at the U.S. population, there are about 1 million people, or a little bit more than 1 million people in the U.S. that have problems with congenital heart disease at the present time.
Now, do we know what causes congenital heart disease? Is it what the mother or the father ate, or the environment that's causing congenital heart disease?
I mean, for the vast majority, Frank, there's no known causes for these congenital anomalies. There are some genetic abnormalities that happen in families where the father or the mother can pass on a genetic defect to their unborn child, and then that gets manifested in the heart as it develops. It takes only about 8 weeks after conception for the heart to fully develop in the fetus, and then after that it just gets bigger and matures. But most of the heart development occurs in the first 8 weeks of life in the fetus, in the womb. So there are a lot of folks that may not know that they're pregnant at that time, may have taken some things that could sometimes cause birth defects, and then when you go back and ask them, they may not recall any of that. But for the vast majority, over 99% of heart defects, we really do not know why they happen. We know that they happen, and it's one of those things. Why does cancer happen? Why do some people have high blood pressure? Why do some people have diabetes? It's one of those things. We still haven't figured out the exact reason for that, and that is part of the reason why we do research in those areas and to try to figure out some of those things long term.
And maybe more money has to be put into congenital heart defect, more research money into this area.
Yeah, I mean, it certainly can't hurt, and hopefully one day we'll have all the answers to all the questions. But the more answers you get, the more you realize that you have a lot more questions you need to figure out.
Now, what are some of the most common heart-related birth defects?
Yeah, I mean, a lot of the defects that happen in the heart, they manifest at different times. So some patients will have problems in the first day of life, and some of them will have problems only weeks later, months later, or even years later.
Now could we tell the first day of life?
Sometimes you can. Sometimes if you hear a heart murmur, you can tell that maybe something is abnormal. And then the baby may be blue, may be ill, may not have enough blood flow to go to the lungs or have enough blood flow to go to the body. And as a result, the baby gets sicker, and then since the baby is still in the nursery, gets treated and gets diagnosed with congenital heart defects. Other babies can go on for years, even into adulthood, without knowing that they have a heart problem, and then only maybe with exercise that they start to feel short-winded and then go get a further workup and evaluation, and that reveals that they have a problem with their heart.
You know, my first question where we mentioned about adults, you know, a person starts having heart problems maybe when they're 55 years old, 60 years old, bypass, stent, and they'll correct that, and they may live another 10 years, another 15 years. And, you know, just think of a baby being born right at the beginning of life, and the life expectancy of that little baby, because he has a congenital heart defect or some type of disease in that heart.
Yeah.
And
no, I mean the life expectancy is a very important question that a lot of families have, and for the most part, the life expectancy is pretty good. It's probably not normal because those babies will eventually have problems sometimes with heart rhythms, with an abnormal heart rate, where the heart rate goes too fast, or sometimes goes too slow. And sometimes they can have problems with exercise, with exertion. But for the most part, the life expectancy is pretty good. It's probably not normal. And although we have not really been doing correction of heart defects for the last 80 years to tell you what the 80-year life expectancy is. The earliest heart surgeries were back in the 1940s and 50s. But for the vast majority of cases, we started really doing heart surgery in babies back in the 1980s. Early 1980s is when a lot of this started taking place. And so we only really have about 30, 40-year follow-up on these patients. And with time, we'll be able to know what the overall life expectancy is.
now, you know, tell us about blue baby syndrome and exactly what that means. You know, because as a commissioner at the Water Reclamation District, in our message to the public that we do every year, our superintendent mentioned about blue baby syndrome, and I'm not too familiar with that. What is it? What is blue baby syndrome?
I mean, you're probably referring to the term that we used to use for tetralogy of Fallot, and tetralogy of Fallot is the most common congenital anomaly of the heart after 1 month of life. So that's diagnosed after 1 month of life. So in the babies below 1 month of life, the most common anomaly is called transposition of the great vessels, where instead of the blood leaving the heart to go to the lungs, it goes to the body, and instead of going to the body, it goes to the lungs. So the vessels leaving the heart are transposed. It's a rare anomaly. But tetralogy of Fallot is the most common anomaly that results in this blue baby syndrome, where the babies are blue because they have too little blood flow going to the lungs, and the blood that comes back from the body to the heart is blue. And when that blue blood that's returning from the body that has no oxygen or very little oxygen, that blood is meant to go to the lungs. When that blood, instead of going to the lungs, makes its way to the body before going to the lungs, then the body's blood becomes more blue. So instead of having the blood that is going to the brain or going to the liver or kidneys, instead of that blood being red, it's a little bit bluer. And so the baby's skin is a little bit bluer, their fingernails are blue, their lips can be blue, and that is one of the, that's how they present. They present as blue babies. So that's a tetralogy of Fallot, and that is caused by obstruction of blood flow from the heart into the lungs. And the blood in the heart flows into 4 chambers. The blood from the body's veins comes to a first chamber that then goes to the second chamber, which is the right ventricle. The right ventricle then pumps that blood into the lungs. And in the blue baby syndrome, or more commonly known as tetralogy of Fallot, in that syndrome there is obstruction of blood flow from the right ventricle into the lungs, and as a result, the blood, that makes it harder for that blood to go to the lungs, and instead makes its way to the left part of the heart that then pumps that blue blood into the body, and that's why these babies are blue. I mean, we correct these anomalies,
yes,
but they're called blue baby syndrome.
You know, Frank, earlier you had mentioned the question of how long a child can be expected to live.
Yes.
And what's really fascinating is that 30 years ago, if a child was born with a congenital heart defect, their likelihood of living a normal life was very, very slim. And so we have come very, very far through research in order to find ways of giving children who are born with congenital heart defects the opportunities to live full and meaningful lives.
You know, Paul, could you tell me about the American Heart Association and what it is doing to combat congenital heart disease?
Certainly, be happy to. The American Heart Association is actually the largest private investor in the country in congenital heart defect research. In the last several years, we've invested $18 million, funded 150 research projects throughout the country. And in addition to that, the American Heart Association funds on an annual basis $150 million worth of research. Much of that research is focused on basic science, basic research, and so a lot of the findings that we're getting from that research is also contributing to the general body of knowledge that we have that leads to the scientific discoveries and advancements in treating congenital heart defects.
And you know, is it once a year or twice a year when I go to the different stores and I see people out there having a collection for the American Heart Association, is that your group out there?
Well,
because you know, to spend $150 million in research, I mean, how do you get this type of funds? Is it through private, through government, or foundation?
No, the American Heart Association takes no government funds whatsoever.
Government funds?
It's all private dollars. It's through heart walks in cities throughout the country, galas, Go Red for Women luncheons, direct mail campaigns, major gifts, foundations, a wide variety of resources.
And so if one wants to contribute to the American Heart Association but gear it towards congenital heart defects, they could make that type of contribution?
Absolutely they can. We've recently created, probably about 3 years ago, a program called Legacy of Life. And there were two mothers that came together after they lost their children and said, we need to do something. We need to increase the amount of funding that's available for congenital heart defect research. And so they created Legacy of Life. Our goal is to raise $1 million. Right now we've raised about just under $500,000, so we've got a ways to go. We've done well, but we have a ways to go. And the $1 million is an endowment, so that entire amount is invested, and the earnings from that will fund congenital heart defect research. And one of the great things about the Legacy of Life is the fact that the entire amount of somebody's gift goes directly into that endowment fund. There's nothing that's skimmed off the top for any overhead or administrative expenses.
100% goes.
100% goes into the fund.
Very few type of charitable operation does that. I'm glad that your group is doing that.
It's very important. We wanted to make sure that that our donors knew that if they give to Legacy of Life, it goes completely into the fund.
You know, Dr. Morrow, is it possible to detect a congenital heart defect in utero, or is it something that can be only detected after a child is born?
I mean, I think more and more we're detecting a lot of these heart defects in utero, or while the baby is still in the womb. A lot of the obstetricians do screening ultrasounds of the baby, and they may notice something abnormal, or maybe the family has another kid that has had a congenital heart defect, in which case they get referred to a pediatric cardiologist. And we have our pediatric cardiologist at the University of Chicago, in addition to other centers in the city that can do ultrasounds of the heart, fetal ultrasounds, and that looks really at the heart motion, at the heart of these babies, and it can tell you whether there is a defect in those hearts or not, what type of defect, and for the vast majority we can predict with pretty good certainty what the actual defect will be at the end. And the more you can detect these anomalies before birth, the more you can prepare for the actual delivery to take place. Because some of these babies need an intervention within the first few days of life. And if you are unprepared to do that intervention, then the baby will get sicker and can get a lot sicker before you are able to intervene, before you even know that this baby has heart disease. And as a result, you fall behind and outcomes suffer. So if you know things beforehand, that this baby has a congenital problem, What we recommend to the families is to deliver in a center where you can do that intervention, if need be, on that baby in the first week or 2 weeks of life, or whenever is necessary, and then you have a better outcome overall. And the more recent studies where we have been doing, looking at babies diagnosed before birth versus kids that are diagnosed after birth with a particular heart defect, the outcomes are a little bit better when you know that the baby has a problem before birth, because then you can prepare the family, you can prepare the various care providers to what needs to be done for that baby.
Now, you mentioned a center here in the Chicagoland area, the University of Chicago. Since you're the director of the pediatric cardiac department, are you the only center here that specializes in this?
There are a number of centers in Chicago. We are one of them. We're the Congenital Heart Center at the University of Chicago has cardiac surgeons, pediatric cardiologists, has pediatric critical care physicians, pediatric cardiac anesthesiologists, and nursing staff that all care for kids with congenital heart defects. Some of these babies will require surgery. Some of them will require cardiac catheterization and further procedures on those babies. We are one of a number of centers in the city, and in addition to sort of the other academic centers, there are a number of private practice hospitals that have centers. But we certainly pride ourselves with the care that we give our patients.
Now you mentioned 1 out of 120 has a congenital heart defect. How many do you have a year then coming through your hospital at the University of Chicago?
Yeah, I mean, we typically, it depends what you mean by the numbers, because some of them require surgery, some of them require nothing and just follow-up. But we have clinics every day of the week, every day that see somewhere between 20 and 30 patients each day.
Is that right?
And some of these are return patients, some of these are new patients. Being a big academic medical center, we see a fair number of patients that will require interventions or procedures. We are also an active heart transplant program for babies, a pediatric heart transplant program, one of 2 in the Chicago area, and we can provide the whole spectrum of support for babies, from intervention to surgery to other procedures, whatever needs to be done for those babies.
You know, I could see myself getting a bypass. I'm 5'5". I weigh maybe 135 pounds, but to do an operation on a baby so small, and his heart is so tiny as compared to an adult, how are you able to perform such intricate surgery on such a small and vital body? You know, they're very small.
Yeah, I mean, a lot of what we do in the baby's hearts is with the use of magnification. We use about 3.5 times magnification to look at the operative field and do our work. We also have other assistants that help us with these procedures, but a lot of it is doing it repetitively and doing it for a number of years. A lot of the actual work in the baby's heart, even though it's a smaller heart.
Yeah, it must be. How small is that?
It depends. Sometimes it's as big as a small piece of lime or a small lemon for the whole heart. But you're not really you're not going and working on vessels that are less than 1 millimeter or less than 0.5 millimeter. You're not doing bypasses in those babies' hearts for the vast majority of these kids. What you are doing are working on the bigger structures, the bigger vessels that go, say, from the heart to the lungs or from the heart to the body. You may be closing some holes within the heart, opening some holes within the heart, whatever needs to be done. And so the actual work is intricate, is delicate. The margin of error is non-existent, is very small or non-existent, depending how small that heart is. So, but as with everything, the more one does, the more the outcomes improve, and the better the benefit for the patients.
Yeah, you know, I can imagine, because, you know, we have bypass, and now bypass is, I think our success rate on bypass is very good. Our success rate in stents are very good. But what is the success on surgery on a baby on the congenital heart defect?
It all depends on what type of surgery it is, and also when it's done. Some of these operations are done in the first few days of life and the first week of life, and those are usually a lot more higher risk than operations that are done, say, at 1 or 2 years of life. Because the baby's heart is smaller, but more importantly, you're also doing a bigger procedure on a smaller heart because you have to do something at that period of time. If you don't do anything to that baby, they will pass away. They will not make it. So as a result, we have to do something. If we have to do something in the first few weeks of life, then those operations usually are a bigger surgery. It's a bigger stress on the body. And as a result, the number of patients that survive those operations is a little bit less than say, if the kids are 2-3 years of life, 2-3 years of age, and then you're doing different procedures on them. So it all really depends on what is the procedure that is done on those babies. Overall, the success rate is outstanding. If you look at all the surgeries done on children, say from 0 to 18 years of age, usually the survival rate for all these operations is about 98-99% overall. Now, if you're only looking at kids less than 1 year of life or less than 30 days of life and looking at the survival for those operations, then that rate is lower. It all depends on the complexity of the various procedures that are performed.
Yeah, because their weight during birth must be, what, 4 pounds, 5 pounds, 6 pounds, 7 pounds, 8 pounds. So.
And the smaller the baby is at the time of birth, and if you have to do a bigger operation on a smaller baby, the margin for error is even less and less. And the stress on that baby's body is a lot more. Yeah. So the outcomes can change depending on the baby and on the deck of cards that you were dealt.
Also, what are the chances that a child born with a congenital heart defect will lead a normal life?
I think like Paul said earlier, I think our chances now of having that person reach adolescence, adulthood, have children of their own, and have a family, I think those chances are very good. 20, 30, 40 years ago, those chances were very small that they'd even reach adulthood. And even nowadays, in 2008, if you go to the rest of the world, there are a lot of places in the world where those children have no chance of survival. Yes. They have no chance of leading a meaningful life because there is no local expertise to take care of these babies, whether it's surgery, whether it's cardiology, whether it's critical care, whether it's anesthesia. So those babies, as a result, never make it to adulthood. And the blue baby syndrome, the tetralogy of Fallot kids, those are one of the few anomalies where they do reach adolescence in some parts of the world, in the developing countries, because only the fittest survive till that point, and then sometimes those kids get operated on and get repaired. So, but if you look at our U.S. statistics, the chances of reaching adulthood are actually excellent.
Now, I'm just wondering, do they have to follow throughout their life certain type of diet, or could eat the normal food, or is it strictly eating raw vegetables? Become a vegan.
Well, as with anybody, adult or child, we advocate that every exercise and not smoke and eat vegetables and fruits. There are usually no dietary restrictions for any of these children. They're like any other adolescent or adult. They can eat whatever they want, and children will eat whatever they want for the most part.
We all watch.
Until they get older, and then they realize that you can't eat food with a lot of cholesterol in it and not get away with it.
Yeah, the high saturated food, unfortunately. Paul, research is obviously so important to understand this disease.
Absolutely.
And how does the American Association ensure, and you mentioned that it is funding the most promising research related to congenital heart disease? How do you make sure? And who decides this too? It's hard. Your money comes in, they say we're going to do this kind of research, this kind of type of research.
Sure. Frank, that's a good question. Essentially, we have a very, very sophisticated peer review system. And so when a researcher submits a proposal to the American Heart Association, That goes through peer review, and the peer review panels are people, are experts in the field. They are cardiologists, they are researchers who have been doing this for many, many years. And when the applications are being reviewed in peer review, they are blinded. And so the peer review committee doesn't know who the researcher is that's presenting it, doesn't know what institution they represent, doesn't know what part of the country they're from. And so truly what happens is they are able to assess that program completely based on the merit of what is being proposed. And so that really is a critical part of what the American Heart Association does through its research programs in terms of really ensuring that the most highly meritorious research is what's actually being funded.
You know, your name is the American Heart Association, but do you only give funding to research done in America, or do you give it to Europe, like England or Italy, other parts of the world?
No, all of our research is funded right here in the U.S.
And other countries must be doing their type of research also. There must be
Indeed,
other artists.
Absolutely. Yep.
You know, doctor, with a baby with congenital heart disease face a lifetime of operations throughout his life. You know, he has it at the beginning of his life. And so as he goes through his life, how many more surgeries does one need as they grow older?
The vast majority of these children will only require one operation or one intervention, and some of them do not require any intervention. Some of them require some medications, some follow-up, and adjusting some of these medications in order to get them the best outcome possible. Some kids will require a catheterization, a cardiac cath, where they go in the groin and they shoot dye and they close some holes between various heart chambers, and that may be all they have. They may not require surgery. Some children do require an operation, and of those that require surgery, most of those children do not require a second operation or a second surgery throughout their life. Some of them will require another operation, and some of them require repeated operations every 10 years or 20 years. For instance, the most common situation that happens is if you're replacing a heart valve. And so for instance, a baby that's born with 3 valves in the heart and not 4, as is normally the case. So if you only have 3 valves, you need a 4th valve. So as a baby, in the first few weeks or months of life, you implant a valve, you stitch in a valve from either another human being or from an animal. But that valve is cadaveric, or is a tissue valve that does not grow. So as the baby grows and gets into a couple of years of life, that valve does not grow and gets smaller. Needs another operation to replace that valve. The kid gets bigger, now is 8, 9 years of age. That valve still doesn't, the second valve hasn't grown. You have to replace it again. So some of these patients require valve operations lifelong, but the vast majority require only one procedure on their heart, if any. Some of them do require follow-up, and very close follow-up with cardiologists that are able to diagnose congenital heart disease, able to treat it with medications, and fine-tune those medications to ensure the best outcomes. But we always advise our patients and our families that they need to follow up with a cardiologist for the rest of their lives, as long as they're diagnosed with a heart defect at birth, because you never know what happens 50 years down the road or 40 years down the road, and sometimes you can have an abnormal rhythm or palpitations that happen long term, that if you're not being followed closely, you may get a worse outcome. So we advise those families that their babies need to follow up lifelong.
Now, you mentioned following up with a cardiologist. You're the surgeon, so you perform the surgery. Mm-hmm. Then once that's completed, then they have to find another doctor.
Yeah, I mean, within various programs, such as the Congenital Heart Center at the University of Chicago, we do have surgeons and cardiologists working together. So we have a number of cardiologists that see the patients before surgery, diagnose what the problem is, do an echo or an ultrasound of the heart that is a non-invasive study that just basically it's a probe over the heart and it shows you the pictures of the heart anatomy. Then they come, say, if they need surgery, they come get their surgical procedure, and then they get back to their cardiologist, who then follows them for their lifelong.
You know, it must be hard because you're the surgeon, Dr. Morrow, and you perform the surgery, and the parents are in another room, right? And then after the surgery, the couple is devastated about their newborn baby. I mean, how do you explain this? I mean, do you do the explanation? Do you become a social worker now? Or, you know, you're the one that's performing the surgery, and you're probably the one that talks to the parents, right? So how do you explain that to the parents? Become a social worker then?
Well, we always try to give our families as much information about the baby's heart defect as possible, because an informed parent can really care for their baby a lot more than a parent that may not know all the details about that heart condition. So we before surgery, the cardiologist and maybe the neonatologist or their primary care physician may sit down and talk to them a little bit about their heart defect. If they need surgery, they come and get referred and see me in the office. And
yeah, because you're considered the expert.
That's what they say.
Yeah, and so I mean, do you go and talk to them also?
Yeah, so we sit down with myself, my nurse practitioners, and the family and their child, and we all sit down. We explain the heart defect. We have some color pictures we give them of the heart condition itself, of a normal condition and the abnormal condition, and we go over how the blood flows in their abnormal heart, and we also then we explain to them what the surgery involves as well. If there's a hole between some heart chambers and we want to close it, we tell them how we close it. If we need to create a hole, then we go over that. If we have to implant a valve or enlarge an artery, then we sort of go over all those details. And then we also go over the recovery period after surgery, because it is a big stress on the body. It's an abnormal physiologic stress on the body. Sometimes we have to stop the heart and work inside the heart to repair various defects, and we use a heart-lung machine. There are some issues that can take place after surgery that we go over with the families, some of the drains that have to be removed, some of the lines and catheters that we put in that all have to come out before those babies go home. So we go over all that, and then they come to the day of surgery. We have our nurse practitioners chaperoning those families to the operating room. The nurses during surgery, during the 5 or 6 hours it takes to do an operation, the nurses will update the family on every hour or 2 hours of how things are going in the operating room. And then when we're done, I come and sit down and talk to them and let them know what happened to their baby boy or baby girl, how things went in the operating room, what to expect going forward, and how long we think they'll be in the hospital for.
And you know, and then after that, the parents need some other group besides the doctors and the nurses, where they could talk to, and that's where I met Joe Goldswick. Him and his wife belongs with a group called Little Mended Hearts.
Mended Little
Right, Joe?
Hearts.
Mm-hmm.
Yeah.
Yes.
And Joe, explain how your group takes over and helps the doctors.
Mended Little Hearts is a program that was designed by Mended Hearts, which you know of, which is the adult support group for recovering heart patients and their caregivers. And about 2 years ago, I got involved with the pediatric end of it and Mended Little Hearts, to the point where I am going nationally and setting up support groups for parents who have children with heart defects. We are doing it in affiliation with many of the hospitals, where we do monthly meetings and bringing experts like Dr. Mora.
I'm glad you have Dr. Mora.
To inform the parents as to what is happening in the area. We bring in people like Paul, who can update them on the research and the funding that's being available for congenital heart defect. We give them, American Heart has a great many brochures and information that we can make available for education purposes. We do internet visiting, parent on parent. We will do telephone visiting and face-to-face visiting on parent to parent. And it's kind of interesting what I found when I first started, and we now have, I believe it as of right now, 30 federally chartered groups around the country.
Now, you said it started 2 years ago, Little Mended
2 years
Hearts?
ago.
And who started it?
It started as a program of Mended Hearts, the adult group. It became an item that our executive vice president at national office started. Unfortunately, she passed away a few months after she started the program, and it was floundering, and I had the time and the passion to do it, and so I volunteered to go nationally and pick up the program. At that time, we had 5 or 6 groups, and as I said, now we have 30, and growing all the time.
And Paul comes in to help Little Mended Hearts, and, and we have our
The interesting thing is when you talk to these parents, the fact that their child has a congenital heart defect is not only emotionally and financially devastating for them, but the idea that with all the information they were given, they really had no one who had experienced it that they knew of that they could talk to one-on-one. They were getting professional advice and medical advice, some of which they understood, some of which they couldn't comprehend.
Yes.
And so consistently what they said to me is 2 things. I would not like to see any other parent go through what I had to go through and not have a source of information. And we must get more money for research. That is the utmost important in our lives. Not my personal financial problems, not my emotional problems. We must cure congenital heart defect.
And this is where the American Heart Association came in with Paul.
Absolutely.
As you know, Margie, my wife, is a heart survivor.
Yes.
I got involved as a volunteer for American Heart about 19 years ago. And in my opinion, that's one of their greatest assets, is their network of volunteers, which drives all not-for-profit organizations. There are many opportunities to get involved as volunteers for a whole host of different programs, including state and federal legislation.
So you have a chapter, you first started here, was the first chapter here in Chicago?
My first group that I started in Chicago was at Dr. Morris Hospital.
Dr. Morris Hospital?
Comer's Children's Hospital, yes.
And that group is still going, Dr. Morrow?
Yeah.
Do you work with that group, the Little Mended Hearts?
I mean, the mother of that started that group was had a baby that had a heart transplant that I had done a few years ago. So it's a nice way of getting together with other families, support structures. I think the support structure really is very important, because those families not only thought maybe that they had a normal baby to begin with, but now they have to deal with the emotional trauma of going through a procedure or going through surgery at such a delicate young age. And it's always helpful when they are talking to another family, like Joe's families, when they can share some of those experiences, and so when they so when they share some of those experiences with the other family members, it's always it makes them go through that procedure first better informed, but second more prepared as well to know what to expect, what consequences there are, and to talk about it, to have somebody to talk to. I mean, we have social workers that talk to these families, but it's always helpful when they have another family member that they can talk to, or another family that has had to go through this before.
Now, who talks to them on the financial impact of the family and when their baby is born? Is it you, Paul? Is it a social worker? Do you come in also on that? You know, because to me it looks like you, as a doctor, play a big major role, because they look at you as the expert, and who else can't they talk to you? Because, you know, I know you're not God, but you're the expert that they may want to call. Do you talk to them on the finance also?
I mean, as you know, in the state of Illinois, as in every other state, there are no children that are uninsured. Every child is insured with Medicaid at the very least. So and Medicaid will pay some of the bills. It doesn't pay the whole bills, but at least it provides that patient with insurance, with access to medications, with access to healthcare providers, and then those that can take care of the issues. So if somebody does not have the resources, then the state insurance programs, the public aid programs step in. Of course, private insurance steps in as well for those with private insurance, and those allow the care to be provided. The difficulties sometimes happen if somebody is an illegal alien or is an immigrant from another country that still hasn't registered through the system, so they cannot when they have no insurance, it becomes a lot harder. But luckily, at least for pediatric patients, it's a state mandate, as in other states, that all these kids do get access to public aid, to public insurance, Medicaid at the very least, if not private insurance, depending on what their families can afford. So from a practical standpoint, it doesn't matter what their insurance status is. From my standpoint, everybody gets treated the same. But also from the family standpoint, yeah, it's a burden on these families. The financial burden, certainly one cannot underestimate it. But there are a lot of support structures, both citywide, hospital-wide, even statewide, that sort of jump in and provide services to those families, such as the WIC program to provide babies and their mothers with formula and for nutrition. There are programs that provide medicines for these families if they don't have the funds to purchase the medications necessary to take care of their sick baby. So there are a lot of programs out there, non-government programs and government programs, that chip in to make ends meet. I know it's a big financial burden, but at the same time, for the vast majority of these patients, the vast majority of their financial burden is taken care of by somebody else, by an insurance company or by the government. Contrast that to other parts of the world where there is no insurance program, where there is some public aid, but it's not really as developed as it is in this country, and a lot of these patients have to pay out of pocket for everything. And that's why you have some maldistribution of care in different parts of the world, because when the family has to pay out of pocket for all the care, then a family of 5 or 6 children may decide that one child, it's not justifiable for that one child to take up all the resources for the whole family.
Yeah, you know, Joe...
in defense of the program, I have not anywhere in the country heard of a family whose child was denied treatment because of finances. However, what I see happening, there are many programs where a parent has his insurance through an employer, and that might be HMO coverage, and the hospital where he needs his treatment is out of network.
Yes.
They incur huge debts. For many of the state programs and federal programs, you must be almost at poverty level, if not at poverty level, to get any assistance. And so these families, most of my families, I would guess probably better than 90% of my families, are in bankruptcy protection because of the financial burden.
Is that right?
We have many of our families who have formally had to go through divorce proceedings so that one of the parents will continue to work, keep their the one who has a better job. Yeah. The second parent takes custody of the children so they can apply for the state and federal programs. It's a sad way for them to have to live.
Now, Joe,
but I have not heard of any that have been refused treatment in the United States that I know of, ever.
Now you're the area regional director here in the Midwest?
I am the regional director in Midwest for Mended Hearts.
For Mended Hearts?
However, I am doing Mended Little Hearts on a national level.
On a national level?
I will go anywhere in the country where there's a desire and a need for a group.
Okay, you hear this audience? You could call Joe, right?
Absolutely.
And if you want to start a group any place in the United States,
I will be there.
Joe will be there to set up a group called
Mended Little Hearts. Mended Little Hearts.
Mended Little, and explain what is Mended Little Hearts. The mission.
Mended Little Hearts is a support group for parents with congenital heart defect children. Simple as can be.
And you have what, 30 groups now?
30 groups federally chartered now.
And throughout the United States?
Yes.
Name some of the states.
Alaska, Oklahoma, South Dakota, Minnesota, Wisconsin, Illinois, Indiana, Iowa, Virginia, Florida, Ohio.
Well, we got 50 states, right? So you're
we've got a long way to go.
A long way to go.
As you know, in our adult group, we have 270 chapters.
270 chapters in the adult group and 30 in the Mended Little Hearts. And how many approximately are in each group on the average?
It varies at times because many of these parents come from other states, and it depends on how long their child has to be.
Oh, you mean they come from another state, they go to the hospital and
for their procedure
for the procedure, and then they join the
group while they're here.
While they're here, and then when they go back home, there's no.
I would guess right now our average membership per group in the Mended Little Hearts group is approximately 30 to 35 families. 30 to 35 families.
Yeah. And this is where the internet comes into play, right?
Yes.
I'll bet you because of your younger families that are used to getting on the computer.
We have a national website. Each group has its own local website. And yes, they do communicate. They also use the Yahoo websites to communicate with each other.
And you personally go to every 30 chapters throughout the United States and set it up?
I try to make them all.
Yeah,
to set them up, yes.
And
I also try to make all the meetings that I can.
And if someone wants to form a Mended Little Heart group in that state, they form a corporation, you say, or non-profit group?
It's a not-for-profit.
A non-for-profit in that state, but they belong with the national.
Correct.
And is that part of the American Heart Association group, Paul?
Actually, it's not part of the American Heart Association, but the American Heart Association works very closely with Mended Hearts and Mended Little Hearts. We provide some office space for them. We provide grants to help them with their operations, and so it's a complementary relationship that we have. And I think what's coming across to me as all three of us are talking is that each one of our organizations plays a critical role in addressing the overall issue of congenital heart disease.
I'm glad you mentioned that.
The American Heart Association is there doing all of the research. Dr. Moore and all of the other pediatric surgeons throughout the country are providing the medical care, and then Mended Little Hearts is coming in and providing the emotional support afterwards. So it really is a terrific relationship that we have with each other.
That's excellent. Now, Paul, does every research project get funded?
Oh gosh, I wish it did. No, absolutely not.
Because each research project must be so important that for them to vote on A over B, it might be just a small.
Exactly.
Say, we'll go to A because B just doesn't have this tiny little bit more research.
While we're funding $150 million a year nationwide in research, that represents only the top 23% of proposals that were submitted. And technically, we want to fund 50% and up. 50%. And so that is what we call the critical gap. And so we don't have enough dollars right now to fill that gap and to fund every single highly meritorious research proposal that we get.
Dr. Morrow, when you do an operation on a congenital heart defect patient, are you also doing research? Are you doing research on every operation that you do and provide that in a paper?
Yeah, I mean, we have an active research program at the University of Chicago. We have several protocols in place. One of the protocols is to collect any tissue that we would normally throw away at the time of surgery. Instead of throwing that tissue away, we collect it and process that and store it in a tissue bank, and then later we'll be doing some various more detailed research projects on that tissue that we're storing. We have a number of cardiac pathologists and basic scientists who do some very basic research on congenital heart disease, say looking at the development of the heart in the first few days as the heart gets formed. There are a number of projects that we're involved in that look at outcomes of these patients, how they fare after various procedures, whether it's sort of here at the University of Chicago or whether it's nationally on a national level, grouping a lot of different diagnoses together and looking at their outcomes, looking at what happens to them 5 years, 10 years down the road, and long term as well. So there's a number of research projects out there. We are very active in that as well, both on a human level, collecting tissues from the OR, from the operating room, and also looking at outcomes research, what happens to these patients, and also on a basic science level and looking at the development of the heart in the first few hours, days of life.
You know, are we doing more, spending more research money in congenital heart defect here in America as versus in Europe, or who's spending more money? You know this, Paul?
You know, Frank, I don't know the answer to that.
No.
I don't know. I can tell you that we do fund, just in Chicago alone, we currently have $17 million worth of research going on, 134 projects. Illinois is part of the Midwest affiliate for the American Heart Association, and within the 11-state Midwest affiliate, we are currently funding $95 million worth of research. So I know we're doing our part here. I don't know what other countries are doing.
Well, the reason why I say is that the #1 cause of death for a male and female now is the heart. And I don't know if we in America are spending enough money for this type of research, because it is, you know, the woman wasn't #1, but now it is. And so that's why I asked this question about research, because it's very important. You know,
if you look at research funds as they're being given to various research projects nationwide and also internationally, the United States has by far always been the leader in terms of medical research. That's across the board for all the different anomalies, whether they're in adults or children. And by far, the National Institutes of Health funds a huge amount of money that goes to various research projects at various institutions nationwide, and that is part of the attractiveness of the United States for a lot of other medical researchers that come here and do their research because of the availability of funds. It is becoming more and more difficult to get funds these days for various research projects, because the amount of money that the National Institutes of Health, the NIH, has nowadays is a lot less than what it was a few years ago. Now with the economy being a little bit worse and
yes,
that money becoming scarcer, so it becomes more difficult for those institutions to provide money for research projects. So when the government cannot fill in that gap, other organizations such as the American Heart Association have stepped in and are providing some of the funds necessary, but it's still never enough, and there's always room for more funding for more research.
Sure, because nationally, how much money is spent to care for babies born with congenital heart defect? Who could answer that? Do we know how much money is spent?
Well, I mean, I think there aren't a huge number of grants looking at congenital heart defects, and there are a lot of different grants that somehow relate to that, such as development of the rat heart or a mouse heart or animal hearts. There are grants that look at outcomes research. There are a lot of grants that look at various psychosocial factors that impact the development of a baby, whether it's related to the heart or otherwise. There are grants that look at environmental causes of various congenital defects, including heart defects. So there are a lot of different grants,
factors.
but it's in the millions of dollars in terms of the amount of funds that are given out every year for congenital heart disease related research. But we still don't really have most of the answers. There are still a lot of questions that are out there that we really have not come even close to answering. What causes congenital heart disease? What causes some of these problems? Why is it that some hearts have 4 chambers, which is the normal heart, and some hearts have only 2 chambers or 3 chambers? Why is it that some valves form and others don't form? What causes some kids to present with the same type of illness in the first few days of life and a very critical, being critically ill, and other kids takes them 2 or 3 years to manifest, and they have a less severe manifestation of that same defect? Why is it that some patients fare worse than others, even with the same defect presenting at the same time? Some of them have worse outcome than others. So there's a lot of unanswered questions, and we really don't know the answers to most of them.
And this is where research helps, that eventually in how long it takes, 5, 10, 20 years to try and solve this problem, especially in the environmental, because that's my field, the environmental. We do a lot of research. And right now, you read the paper, global warming, climate effect, pesticides, herbicides, compound emerging concerns, and how it affects the health. So I think, as you mentioned, America, we're facing a financial crisis here in America, and I don't know how long that's going to last to give money to research, because it will have an impact.
You know, Frank, to answer the question that you asked earlier, we're actually in this country spending about $2.2 billion with a B each year on caring for children who are born with congenital heart disease. And so, I mean, that's a huge chunk of money every single year. And so to do the research to figure out what the causes are of congenital heart disease is so important, because ultimately we'll get the answers, we'll know how to care for the children better, and we can reduce that $2.2 billion price tag.
And, you know, I'm glad that I have 3 experts in different fields, as you mentioned, Paul, because it's important to have Joe with his Mended Little Hearts group, a support group. It's important to have the American Heart Association for their funding on research project, and also public relation, informing people how to take better care of themselves.
Absolutely.
To have a better heart, right? Basically, that's what the American Heart Association is supposed to do, right?
That's a big part of what we do. 80% of heart disease in this country is preventable, and so we've got to get that word out there to people and tell them that you can change your destiny by eating healthier and being physically active.
Yeah, and then also we have the expert from the University of Chicago, Dr. Basa Mora, and he's the director of the pediatric cardiac surgery, a surgeon. Now, how long have you been a surgeon, doctor?
Well,
60 years?
120 years.
120 years? Tell us about yourself.
Well, I've been in Chicago since 2005, and before that, I was in Boston at Harvard Medical School. I did my training there, and then I stayed on staff there for a couple of years at Boston Children's Hospital, part of the Harvard Medical School environment. And then I came here back in 2005 to the University of Chicago. So it's I've luckily been sort of traveled in different parts of the country, and have had teaching and educational opportunities in a number of states.
Well, thank you very much, and I hope we can solve the heart problem here in America or throughout the world.
Thanks,
Indeed.
Frank.
Thank you very much.
Thank you.
Thank you.